Hello, and thank you for joining me. I'm Arica I. James, and I'll be walking you through my evidence based practice project designed to reduce systolic blood pressure in underserved communities. Let's jump right in for a quick review of today's agenda. Today, we'll explore a critical healthcare challenge: uncontrolled hypertension in Black and Hispanic adults aged 40 and over, and discuss a culturally competent community based intervention designed to reduce this disparity. This project reflects not only the research and strategy behind effective blood pressure control, but also the deep need for equity, trust, and representation in how care is delivered. Thank you for taking the time to engage in this work. I hope it sparks meaningful thought and action. Q. What inspired the focus on Black and Hispanic adults over 40? A. This group experiences the highest rates of hypertension-related complications and the lowest rates of successful blood pressure management, yet few interventions are culturally tailored for them. This intervention is designed to be relatable, relevant, and community-driven. Instead of using a one-size-fits-all approach, the program aligns education with the culture, language, and traditions of the participants. Cultural competence improves patient trust, promotes consistency, and helps people retain and apply what they've learned, especially in chronic disease management. Q. What defines a culturally competent program? A. It includes bilingual delivery, cultural dietary alignment, spiritual context, and community leadership. It's not just about language, it's about resonance and respect. The original PICOT guided the research and design of this intervention. It asked whether culturally competent education could reduce blood pressure more effectively than standard materials over 120 days. The revised PICOT clarified the intervention duration, 4 weeks, and set a clear outcome: a 10 millimeters of mercury reduction in systolic blood pressure. This level of improvement is meaningful and tied to measurable reductions in health risks. Q. Why did you choose systolic BP as the primary outcome? A. Systolic blood pressure is the most predictive of cardiovascular events in this population and shows clear, measurable improvement with education. Now let's discuss the social determinants of health. We can't talk about hypertension without talking about access. Social determinants of health, like income, transportation, and language, affect every step of the care process. If patients can't afford medication or don't understand provider instructions, they are less likely to manage their conditions successfully. Cultural safety and access to linguistically aligned care directly improve health outcomes. Q. How do you measure the impact of social determinants in this intervention? A. We address them indirectly through access, community locations, literacy, plain language materials, and trust building, faith-based partnerships. In this section, we'll focus on the core issue driving this evidence-based practice project. Black and Hispanic adults aged 40 and older are disproportionately affected by uncontrolled hypertension. Despite advancements in treatment and widespread dissemination of national guidelines, these populations continue to experience poor blood pressure control, contributing to higher rates of heart attack, stroke, and premature death. The problem isn't just clinical, it's cultural, systemic, and structural. Conventional education programs are often developed without input from the very communities they aim to serve. Materials are rarely translated into multiple languages, and they frequently ignore key cultural nuances such as diet, family structure, stressors, or even spirituality. Health literacy is another major concern. Many patients are unfamiliar with medical terms, overwhelmed by generic handouts, or confused by instructions that don't align with their lived realities. Add to that a long-standing mistrust of the healthcare system, fueled by both historic and ongoing disparities, and we're left with interventions that often fail to reach or resonate with their intended audience. This project proposes to flip that model by embedding cultural competence into every layer of the education process, from who delivers it to how it's presented and where it takes place. By meeting people where they are, literally and figuratively, we can begin to close the gap in hypertension outcomes. Multiple studies confirm that culturally adapted interventions improve blood pressure control and patient satisfaction. Faith-based programs for Black communities and peer-led Spanish language education for Hispanic populations have been especially effective. This body of evidence supports the use of familiar environments and trusted messengers in delivering education. Q. How generalizable are the studies you cited? A. All studies were conducted in real-world settings with minority populations, which makes their models highly transferable to similar environments. Despite the success of culturally adapted models, there are gaps. Most existing hypertension education doesn't reflect participants' spiritual or cultural values. There's also a lack of bilingual content and minimal training for providers on delivering culturally safe care. This project fills those gaps by tailoring both the message and the messenger to the audience. Q. Has anyone attempted to close these gaps before? A. Yes, but many were single language or lacked scalability. This program addresses both issues with repeatable community-based delivery. The solution is a 4-week program led by bilingual educators in familiar community settings. Sessions are hosted at churches and federally qualified health centers, making access easier. We cover practical content like dietary strategies, how to take medication correctly, and stress reduction that aligns with cultural practices. Q. Why only 4 weeks? A. 4 weeks strikes a balance between delivering meaningful content and respecting the time limitations of underserved adults who often juggle multiple jobs and family duties. Each session includes peer storytelling, food demos, and blood pressure checks. We'll distribute monitoring kits and printed materials in both English and Spanish. This hands-on, interactive model increases confidence and accountability while removing fear and confusion around blood pressure management. Q. How will success be measured session by session? A. Attendance, engagement, and completion of weekly BP logs will be tracked along with qualitative impressions gathered in post-session debriefs. The Johns Hopkins Nursing Evidence-Based Practice Model was chosen to guide this project. It encourages continuous evaluation and integrates patient preferences with research and clinical expertise. That makes it ideal for a flexible, community-based program that must evolve in real time based on participant feedback. Q. Why was the Johns Hopkins Nursing Evidence-Based Practice Model chosen? A. It allows for continuous feedback, values patient-centered adjustments, and is already trusted in clinical and academic settings. This pilot will run over 120 days and will be implemented at 2 federally qualified health centers in Houston. Bilingual community health workers and nurses will lead the sessions. This allows us to reach patients in their own language and through trusted community spaces. Q. Why Houston? A. Houston has a high density of both target populations and federally qualified health centers, making it an ideal environment for piloting. We'll measure pre- and post-program systolic blood pressure to track clinical outcomes. In addition, participants will complete brief health literacy and satisfaction surveys. Small focus groups will also provide valuable context about their experience and what changes they found most impactful. Q. How will bias be reduced in evaluating outcomes? A. We'll use standardized tools, objective BP readings, and focus group facilitators from outside the program delivery team to enhance neutrality. If outcomes fall short, the program will be adapted. We may extend it to 6 weeks, include more one-on-one coaching, or adjust materials based on feedback. Monthly review meetings with stakeholders will help guide those adjustments in real time. Q. What's your protocol if more than 50% don't complete the program? A. We'll evaluate logistics, session length, and delivery style immediately and test revised formats through rapid cycle improvement methods. Barriers include limited transportation, digital access, and long-standing mistrust of the healthcare system. To reduce those, we'll offer printed materials, rideshare support, and flexible scheduling. Most importantly, trusted messengers, people from the community, will deliver the content to build confidence and rapport. Q. What's your contingency plan for low attendance? A. We'll offer makeup sessions, transport vouchers, and phone check-ins as backup support to keep participants engaged. This evidence-based practice project doesn't just aim to lower blood pressure. It aims to change how we engage with underserved communities. It's scalable, rooted in trust, and centered on people, not just statistics. Thank you for your time, and I welcome your thoughts and feedback. Q. What are your next steps if the pilot is successful? A. Scale the model to additional clinics, apply for grant funding, and publish the results to promote replication. Thank you all for your time and attention during today's presentation. I appreciate the opportunity to share this work and look forward to any feedback or questions you may have. Your engagement and support are truly valued.